Buenas tardes a todos. Muchas gracias por participar en el segundo webinar de BiblioPRO. Good afternoon from Spain. Thank you for participating in this webinar, the second one of BiblioPRO. I am really pleased to welcome you to this webinar, which comes with a luxury of presenters. Of course, Dave Cella as first and principal, who will be introduced by the moderator of the webinar, Carmen Rodríguez. Carmen is a senior researcher of Instituto de Salud Carlos III and member of the BiblioPRO Scientific Committee. The main presentation is about PROMIS, an initiative of the National Institute of Health of the United States, which represents the latest revolution in the field of patient-reported outcomes with the development of calibrated item banks and computer adaptative test, CAT. After we have two short presentations with Gemma Vilagut, the Spanish researcher with most knowledge and experience about PROMIS, and Jordi Alonso, the contact point for the PROMIS National Center in Spain and co-director of the BiblioPRO Scientific Committee. We really appreciate all of them for shedding light about PROMIS, since a great number of persons who contact BiblioPRO ask for this family of PRO instruments, demonstrating that there is a growing interest in their work. Thank you. Your turn, Carmen.
Thank you, Montse. Buenas tardes, good afternoon. And thanks, Montse, Jordi, and the organizers for inviting me to moderate this session. Today, as Montse said, we are going to have an interesting program, starting with Dr. Dave Cella's presentation. It is my pleasure to introduce Dr. Cella, who is the Ralph C. Paffenberger Professor and Chair of the Department of Medical Social Sciences at Northwestern University Feinberg School of Medicine, and an elected member of the National Academy of Medicine. His research portfolio extends from health outcomes measurement and application to clinical trials, comparative effectiveness, and learning health systems implementation. As an expert in applied health status measurement, he has led the development and validation of the FACIT measurement system, PROMIS, NeuroQual, and the emotional health domain of the NIH toolbox. These measurements are used around the world by thousands in clinical practice and research. His talk today is on PROMIS, patient-reported outcomes measures, fixed instruments versus adaptative forms, which ones to use, in which he will introduce the various types of PROMIS measures and applications. He will discuss the characteristics, possibilities, and the various ways of applying PROMIS in different contexts: research, clinical practice, and population monitoring. If you have any questions or comments, please leave them in the chat. So, Dr. Cella, it's your turn. The floor is yours. Thank you.
Thank you very much, Carmen and Montse, for that kind introduction. I will now share my screen with you so we can go forward with the presentation. Let me just check and make sure you can see the screen. Do you see the first slide? Is that a yes?
Yes.
Okay, thank you. Well, it's my pleasure, really. And again, thank you for that kind introduction to talk with you about PROMIS and how to make choices about all the assessment options. And there are many with regard to PROMIS. I'm going to start by just giving an overview of PROMIS from its beginning in 2004 to today. There have been more than 50 standardized research protocols that have been organized by evolving PROMIS standards. And over 100,000 people have contributed data that we use for our referencing and interpretation information. There are over 2,000 questions across adults and children in many different languages, including English and Spanish. We focus on universal concepts as opposed to disease-specific approaches, although there are disease-specific extensions of PROMIS that we can discuss. And what began as a United States NIH effort to standardize patient-reported outcomes really has expanded now into clinical practice applications, quality of care measurement, population measurement, and international adoption. And I'll cover each of these with you briefly. The publication rate has really accelerated, particularly since 2014, when the actual funding for PROMIS ended from the National Institutes of Health. After 2014, the great majority of publications have been from non-PROMIS investigators, whereas in the first 8 or 9 years, most of the publications were put forward by people funded under the PROMIS initiative. So it's an indication of how this has really taken off outside of the network of the original funding. The domain framework for PROMIS is organized around physical, mental, and social health. And you can see that there are some sort of core domains up in the top panels, including physical function and pain and fatigue and depression, anxiety, and ability to participate in social roles. But then there are a host of additional domains, just a sample here shown on the screen. And this is the domain framework for adults. There's another one for children that's similar in structure, but some different content, of course, tailored to the relevant concepts associated with childhood. To give you an idea of PROMIS item banks, it's different from item libraries in that a bank is a collection of items that are calibrated to measure a single health domain. And this slide illustrates physical function as a health domain, where you can consider people ranging from those being extremely limited in their physical function all the way to those people who have no limitations and are even perhaps elite athletes. And the physical function item bank has items that are targeted to this full range of physical function, which allows for you to make choices in selecting questions that are going to be appropriately targeted to your particular sample or population. The metric for PROMIS is the T-score with a mean of 50 and a standard deviation of 10. And we reference that in almost all cases to a general population. Some measures, such as stigma and alcohol use, are really referenced to a subgroup of the general population for whom that's relevant. But for the most part, the PROMIS item banks are referenced to a general population center of the mean of 50. And that allows us to do interesting comparisons. This is a paper that was published by Ding and colleagues looking at different countries and depression during the COVID era. You see the red line drawn at 50, so that's the sort of average for the general population. And in some countries, there's less depression than average during COVID era, but in other countries, there's more. So you can check for where Spain is here at around 53. Slightly more depressed than the general population. The U.S. up closer to 55, which is indicating that it's considerably more depressed than the average for the general population. Some of which is no doubt due to the stresses of the COVID pandemic. Same thing with anxiety, where you can compare across different countries. Again, Spain and the U.S. here pretty close to one another, but all in the sort of 57 to 60 range, again, indicating a good amount of anxiety in the COVID era. So what we're going to focus on today are the different types of PROMIS measures and how to choose from one versus another. They're all derived from item banks. There are fixed length forms by each individual domain, and there are some over 100 domains to choose from across adults and children, and they tend to range between 4 and 10 items long. We also have health profiles. It's a 29-item profile, 43 and 57 items. I'll show you that on the next slide. And the PROMIS Global 10 is very popular. Is 10 items that give you a read on overall or composite physical health and composite mental health summary scores. And then finally, we have computerized adaptive testing, which is the dynamic approach items that are going to be most informative about a person given how they've responded responded to previous questions. Here's an illustration of the profile short forms. So we have these 7 core domains of anxiety, depression on mental health side, fatigue, pain, and sleep on the physical health side, and physical function and social function. Fatigue, pain, sleep, and physical function on the physical side, and social role on the social side. And these now form the profiles. If you have 4 items from each of these domains, that's the PROMIS 29. 6 items from each domain, that's the PROMIS 43. And 8 items from each domain is the PROMIS 57. You might notice that you multiply these numbers by 7, you don't get 29, 43, and 57. You get 28, 42, and 56. That's because we add the 0 to 10 pain item to each of these profiles. Here's an example of a short form for physical function. This is the shortest of the short forms that's off the shelf. There are many to choose from, actually, in this particular domain. Now, the Global 10 has content on general physical health, general mental health. It captures physical function, social function, and fatigue, pain, and distress. You get 2 scores from this. You get a physical score and a mental score. And you can actually look up on a lookup table. Many of these are available on the website. The raw score total and look up what that T-score would be based upon work that Ron Hayes and colleagues did some 12 years ago. Now, what are the pros of these profiles? Well, one is that they're free and they're accessible. Another is that they're integrated into many data collection tools. You can complete them on paper, which is convenient for many applications. And there's a scoring service or these lookup tables that I showed you an example of for scoring. The scoring service is something where you submit your data to the service and it gives you the report. This is a freely available scoring service. They cover multiple domains and the domains that tend to be important across many different health conditions. What are the cons? The negatives are that the item content is not tailored to the respondent or to the population. They're sort of off-the-shelf pre-selected items. They happen to be some of the most informative items in each bank, but they are pre-selected. And that tends to make them a little less sensitive at the extreme. So if you have a very healthy sample or have a very impaired sample, you might want to go to a more tailored or targeted short form for those assessments. Now, how about the off-the-shelf short forms? The pros of those are that, again, they're free and accessible. They're integrated into many data collection tools like the profiles. You can complete them on paper, and there's the scoring service. So a lot of the same sorts of advantages of the off-the-shelf short forms to the profile forms. The cons, again, are that the item content isn't tailored to the respondent, and they're less accurate than custom forms or the CAT at the extreme. So again, think in terms of if you think you have a sample that's going to be at one of the extremes of what you're measuring, the off-the-shelf forms tend to not do as well as a CAT or a customized short form. Now, the pros of the custom short forms kind of are the flip side of the pros of the off-the-shelf ones. They are free. They tailor the content to the population or severity or function level, which is something that you can do in your own examination of the item options. The scoring service can still calculate the score, and you can tailor the length of these to your purpose. You can have a 4-item one, you create a 6-item one, 8, 10, whatever you think, and I'll show you how you can use sample size information to make that determination. Now, the cons are that you need to integrate these into the data collection tool. They're not readily available because you've just created it. There's no immediate scoring without additional effort, so you do need to use the scoring service. It's not a lookup table that you can just return to. And you need some expertise in order to select those items, to be able to understand how to work with these item parameters about discrimination and location, to be able to know what are the difficult items, what are the easy items in a bank. So now to say a little bit about computer adaptive test. The way it works is that in this example, this illustration, you can have a first question that does a pretty good job of covering the full range from low physical function or poor physical function up to high physical function. Although it might cover it coarsely and give you some estimate, you get a response that gives you an estimate of where that person is. and then the computer picks a question that's actually more discriminating in that range, the range of that response option. And then you get another response from the person, and then the computer can really zero in and pick questions that are particularly discriminating right around that estimated score, so that by the time you've asked just a few questions, you get very good precision, and you've covered that full range of physical function in this illustration. So what are the pros of CAT? Well, it is the most precise way to get an individual score across the range of any of these domains. They're automatically scored by the program, and they're integrated into many data collection tools. However, the cons are that you do have to have a computer to do this. There is a fee for data collection tools, so it doesn't come without cost. And it's difficult to select specific item content to include because the computer will do the selecting. So if you care about which items are asked, or you don't have the fee to cover the cost, you're probably going to not be using a CAT. Now, respondents answer different items. That's not necessarily a con, but some people actually like to see people answering the same questions because of a belief that that's really how they're going to get information to compare across people. This is just to let you know that the website healthmeasures.net is really the best source for PROMIS information and access, and also downloading tools. So please register that website address. There's lots of educational material on the website. It's pretty easy to use. Just a quick summary of what's on the site. You get a current list of the available measures. You can see the different data collection tool options, scoring instructions, and manuals you can download. Get interpretation guidelines, publications. You can also cross over to publicly available data sets that you can analyze on your own. Upcoming workshops and events are listed on the site. You get basics on measurement science in terms of introductory tutorials. There's an interactive forum for Q&A, so you can interact with others that are using the site. And then the most popular aspect of the website is the search and view measures, where you can actually go in and look at the measures and download PDFs along with viewing demonstration videos. So the website has tables that include calibration and centering sample information there at the top right. There are G-code severity modifiers, which I don't think are relevant in Spain, but they're helpful for billing in physical therapy settings here in the US. You get score cut points and interpretation guides, and these T-score maps that allow you to sort of understand, like a vignette, what does a PROMIS score of 50 mean in terms of depression or pain or whatever? What does a score of 60 mean? What's the most likely or most probable response that somebody will give to a given question, given a certain score? So it really helps to interpret what these scores mean. There are different interpretation guides. This is the sort of standard general one, where we have on the symptom side up at top and function at the bottom. You'll notice the symptom scores go up because a high score is bad. The function scores go down along the bottom because a low score on function measures is bad. About 20% of the general population falls in the range of what we might consider clinically relevant, either mild, moderate, or severe. And these are sort of general guidelines for interpreting scores. And they've tended to hold up pretty well over time. This is an example of a T-score map you see with depression. So, for example, if somebody has a T-score of 60, you know that they're likely to have said, sometimes I feel worthless, sometimes I feel helpless. And well, actually, their most likely response to all of these questions, except possibly I feel hopeless, which might be rarely, you see the most likely response. And so you can say that a person with a score of 60 reports sometimes feeling worthless, helpless, and depressed, like a failure, unhappy, etc. That would also be an indication of right around what's a clinically significant level of depression. You can also get recommendations for specific patient populations on the website. It's another very popular place to go. Orthopedic surgeons will go to the ortho site. Hematologists will go to the anemia site, oncologists to cancer, etc., and look for what we recommend as sort of a core in each of these disease areas. So here's an example for heart failure, where the recommendation is to measure physical functioning, fatigue, and dyspnea. Lots of activity on PROMIS in orthopedics. The rate of uptake has been exponential in the past 5 years, and it's largely because there's some PROMIS measures tied to reimbursement in orthopedics, but also because the CAT is very popular in this setting to get good individual assessment and identify people who are good candidates for surgery versus not good candidates for surgery, and getting used in that way. I'll show you an example of that. This comes from work done by Judy Baumhauer, in which she tracks individual patients and can show them their scores over time. This is looking at physical function, pain interference, and mood, going from 6th of April out to 1st of June, and identify the point where the first visit is an Achilles tendonitis referral to physical therapy. They improved with physical therapy and went to a home PT program, and you see their scores getting better as that happens. Here's another example from the same group, looking at the foot and ankle surgery, where they can identify in sort of predictive analytic way scores that preoperatively are not likely to show benefit. If you look at the lower right quadrant here, this is a group of patients who at pre-op actually have pretty good physical function. Their score is above 42. And they found that anyone who starts with a score that's above 42 has a 94% probability of failing to meet a minimally important difference or benefit from surgery. So they can discourage people that are already functioning pretty well. Maybe this surgery isn't for you, even though you might feel like you need it. Another point that some surgeons have made in the physical therapy area is that it takes 1 minute in the waiting room to get a PROMIS score on it with a CAT, and it takes 5 to 10 minutes and $52,000 to get a gait measurement. And the evaluation from baseline out to 1 year was just as effective in showing benefit with the PROMIS as it was with the gait machine. Now, this is the slide I mentioned earlier I would talk with you about in terms of identifying when to use a 4-item short form or a 6-item short form or an 8-item short form in this case. So this is comparing information gained from 4 versus 6 versus 8, with 4 being in green, 6 being in red, and 8 being in black. The blue shading in the background of each of these figures indicates the range of T-score where you're getting good quality individual measurement. That is reliability above 0.9, which is considered, very good individual measurement reliability. And you can see you get more information and more reliability across a wider range of that T-score with the 8-item short form. But the 4-item short forms are pretty good in a more constricted range. Remember, I said if you're going to be measuring out at the extremes, you might want to go with something custom or CAT, but you also might want to go with that 8-item form over the 4-item form, because it does push out the reliability to the extremes relative to the 4-item form. But the 4-item forms do pretty well. Now, the next thing is, let's correlate those with full banks. You see the full bank correlations with short forms versus CAT. CAT being the blue circles, short forms being the red squares. CAT always outperforms the short forms to some extent, with physical function quite a bit. It's one of the reasons physical function CAT is so popular, is it does a much better job than the short forms in terms of correlation with the full bank. But all these correlations are high. They're all above 0.8. And most of them are well above 0.9 in terms of correlating with the overall full bank. You can also see, looking at a profile, this is the 57 profile, where we've just sorted into 5 groups. People that say their health is excellent, that's the lower group, the blue group, the light blue group. Very good is the darker blue, good is green, fair is red, and poor is black. And you'll see pretty much the same performance of the full bank versus the CAT versus the 8-item short form. So whichever one you use, you're getting the same relative scores on each of these domains. Now, this is where you can use help, where you can get help in selecting which form to use based upon sample size and power. And you'll see for something like fatigue, you're almost as well off with when you're talking about a population that's likely to be centered around the general population, around a t-score of 50. You're almost as well off with the 4-item short form as you are with the 8-item short form. The difference in those curves, green, red to black, is not that great. Whereas with depression, the 4-item short form is not nearly as powerful as the 6 and 8-item short forms. So this can be a helpful way to decide in a given domain if you think you're going to have a sample that's centered on that general population score, what to use. When you get to a clinical population, the power gets even better. These tools are all really a little bit better, frankly, in clinical populations than they are in the general population. So the power even goes up here, again, showing that difference between 4, 6, and 8-item short forms. I'll say a little bit about population health, because here you can use very short assessments, even as short as 2 items. Sometimes even 1 item can work well in population health. And PROMIS has been studied in U.S. The National Health Interview Survey and other national population surveys, particularly looking at the PROMIS global health measure, looking at physical health and mental health. Now, these are defined target goals set by the U.S. Center for Disease Control to the 4-item physical health measure and the 4-item mental health measure that are both found in the PROMIS global measure. So Ron Hayes and I did some work on identifying what should the target be based upon the population health experts at the Center for Disease Control wanting to have good or better self-reported health using the PROMIS measures. And so we set that target for physical health and mental health at being right around 80, 79.8 for physical health and 80.1 for mental health. And you can see, for example, that people without disabilities are exceeding the target, whereas people with disability are not, in both physical and mental health, are not even close to the target. And so there's a place for significant work to be done in improving the health status of people with disabilities. Can also look at things like sex and race, ethnicity, and identify, looking at that target now, remember it's around 80 based upon the PROMIS score. The total population is almost at the target, but women relative to men are short of the target, so a disparity there. And American Indian and Hispanics and Blacks also below the target relative to Asian and white participants. Again, helping the country set targets for improvement. Same thing here with mental health. Women have a disparity relative to men in mental health, as well as the Native American, Hispanic, and Black groups. Same thing with education. People with lower education are short of the target, whereas people with 4-year degree and advanced degrees have exceeded the target in terms of physical health. Publicly insured patients or people are below target. Privately insured people are above target. So again, it allows us to look and see disparities and inequities that exist in just basic demographics. Same thing with mental health. You see the same gradient of disparity in mental health for less educated and publicly insured patients. So to summarize recommendations on types of PROMIS measures, we have computerized adaptive tests, or CATs, off-the-shelf short forms, custom short forms, and profiles. And the best way to select a measure is to consider your aims of your study, the domains you want to include, the type of measure that you either can use or would be advisable based upon some of the concepts and principles I outlined, and that should then shape your measurement options. I'm going to close now by just saying a little bit and transition to hearing more about what's happening in Spain. Close by talking about translations. There's tremendous activity going on in the translating of PROMIS measures now. There are about 500 translation licenses that are issued annually, in over 70 different languages and almost 3,000 active PROMIS measures. That includes English measures and translations, with 2,500 PROMIS translations and across all of health measures, because it includes NeuroQual and some other things. There are almost 3,000 translations, quite a bit of activity. The most popular domains on the adult side are fatigue, physical function, sleep, pain, and global health. There's growing interest in pain intensity, cognitive function, GI symptoms, itch, and self-efficacy, and emerging interest in sexual function, pain behavior, and social health. We saw a dramatic increase these past 3 years in pediatric and parent proxy measures, including sleep, global health, pain, mobility, upper extremity function, followed by anxiety and depressive symptoms and cognitive function. There's growing interest in pediatric profiles and pain behavior, and emerging interest now in early childhood domains. We've just published a full issue, special issue on early childhood assessment. That is from age 1 to 5. The PROMIS-29 is the most popular profile. It's available in 58 languages. The +2 refers to adding 2 cognition items, so you can get a preference measure or utility measure. That's available in 27 languages. PROMIS-57, the longer profile, is in 13 languages, with the global 10 being in 43 and the pediatric profile in 13. And there's additional work going on all the time. There are measures readily available in Spanish, 287, 140 for adults, 61 for children, 58 parent proxy, and 28 actually of these early childhood parent reports, which are very new. You can get this full list at the website that I mentioned earlier. There's lots in the queue to be reviewed and approved before releasing, including smoking item banks. And with that, I hope I haven't taken too much time. I want to thank you for your attention. Available for questions.
Thank you very much, David, for walking us through the methodological and practical aspects of PROMIS. I would like to invite the audience to send their questions in the chat. But to start, I have a question, a comment regarding the lower correlations between the short form and the cut versions in physical function, and perhaps less for anxiety and depression. What are the implications for its use in clinical practice? Would you recommend using these short forms in clinical practice?
Well, I think if you can use a CAT for physical function, it's probably going to be better, and you saw the data to support that. However, that's not practical in many settings, including our setting. We were using a CAT for some time in our oncology project, but in order to be able to use it across our entire health system, that includes 13 or 14 hospitals and 50 clinical settings, we needed to be able to switch back to paper. And rather than try to get 8 or 10 questions in a short form for physical function alone, we've actually switched down to 2. But we recognize that with only 2 questions, all we can really do is indicate the possibility of a need for more discussion. So it really is intended to be a trigger to begin a discussion about what's going on physically, particularly if the responses get worse over a period of time. So for accuracy of score, I can't recommend a 2 or a 4 item short form in clinical practice, but to begin the conversation, that's what we're doing, and it's better than doing nothing.
Okay, thank you. And what about adaptive tests? You commented about pediatric population or even early childhood. What about people with learning or cognitive difficulties?
Yeah. So usually what we recommend there are proxy measures, of course for kids, for children, but also some for on the adult side. What we usually recommend is having both a proxy provide a report and the patient provide a report. And if it's a situation where over time the person becomes unable or unreliable in the report, you at least have that earlier information to be able to sort of estimate from the proxy report what the patient report might have been. So we advocate for doing both. It's a familiar problem. There's nothing about PROMIS that solves that problem. So no matter what you're using in your assessment, there is the need to be mindful of the possibility of distortion or unreliability of your responses based upon cognitive impairment. I do see another question here.
Yes, there are other questions. Yeah. Dr. Joan Forjas asks, can it be incorporated in electronic health records as CAT?
Oh, yes. So Epic, for example, which is the largest electronic health record vendor in the U.S., has PROMIS in its offering. So if you're an Epic user, PROMIS is there. And there are, outside of the U.S., there are Epic installations that also have that available. So we license the API, the application programming interface that delivers the CATs to Epic, that then passes that along to Epic users. There are other smaller electronic health vendors that also are licensed distributors of the API that deliver these CATs. So that's the thing to look for is whether the vendor includes PROMIS. And if your vendor doesn't, then I think you want to ask them to do that. It's a matter of licensing the API.
Mm-hmm. Okay. There is also several questions by Dr. Jordi Alonso. How item banks were created? And how lengthy are they? And are all item banks equal length?
Yeah, let me start with the last two questions. Sure. And then talk about creation. They're not all equal lengths. They range in length from the shortest item banks are around 20 questions, and the longest one, which happens to be physical function, is 165 questions. So they're quite variable in length. The average item banks are in the range of 30 to 50 questions. And these are smaller than, say, educational testing item banks, which can be thousands of questions. And that's largely because we have multiple response options for each question. You have 4 or 5, usually 5 different response options. So that gives you a lot more information from one question than a yes, no, correct, incorrect type question in education, where you basically have 2 options. You're either right or you're wrong. So those banks need to be much longer. Most of the banks are in that range of around 30 to 40 or 30 to 50 items long. And the longest ones are physical function and fatigue. Mm-hmm. In terms of how we developed them, we had domain teams. There's 7 different domain areas. There's physical function and fatigue and pain, social function, depression, and anxiety. That was one group. And these groups each worked on a sequential approach of literature review and then qualitative work with interviewing people with the problem that we're trying to assess, writing and adapting questions, going through cognitive debriefing then of those questions, and then large-scale testing. So a sort of step-by-step from literature to eliciting concepts to debriefing the items and making sure they're clear to then testing them in a large sample and then calibrating them using item response theory, weeding out questions that don't fit well and didn't perform well, and then creating these item banks.
Okay, thank you. There is also a question by Dr. Montse Ferrer. Can you explain more about Rosetta Stone?
Yes, Rosetta Stone, which is a play. It's on here on the screen here because earlier I had some slides on it. But yeah, I realized I had too many slides, so I took them out. So Rosetta Stone is a play on words. Rosetta Stone, which, as you know, translated hieroglyphics from ancient Egypt into Greek and allowed understanding of hieroglyphics. So we have a similar concept of linking different measures of depression, for example, to PROMIS depression, or different measures of anxiety to PROMIS anxiety, different measures of physical function to PROMIS physical function. There are over 60 of these links on Rosetta Stone. So if you're using something that has already been linked to PROMIS, you could express your score on a PROMIS metric. And this works, for example, in orthopedics. I mentioned where in orthopedics you can get paid for your healthcare delivery based upon PROMIS scores. That's because the Oswestry Disability Index, which some of you may know, is linked to PROMIS, and you can either administer the ODI or Oswestry Disability Index or PROMIS, or and get and submit your quality information using these linking tables. So they have very practical value in healthcare financing. But they also have practical value for comparative effectiveness research and being able to, look at effect sizes of, across different instruments by bringing them all to one common metric. And that would be the PROMIS metric.
There is also a question by Susan Webb. I understand these PROMIS instruments are specially for large population studies or screening rather than specific diseases?
Well, I would say, no, that's not true. They were designed to be universal, as I mentioned, but we don't use the word generic because it has a bad connotation. One of the things that we've learned with a computerized adaptive testing, for example, and item response theory more broadly, is that you can actually get good, precise measurement of specific disease area issues with PROMIS measures. And so the old idea that disease-specific measures are better or more responsive than generic measures is no longer true in many cases. Now, there are some exceptions. For example, with knee function, there are some very specific knee questions that ask about all kinds of positions and abilities with your knee. And PROMIS doesn't go into that kind of detail, although with Dartmouth, we did expand the physical function and pain banks to include knee osteoarthritis. And so in that case, we've taken the general PROMIS physical function and pain measures, added knee-specific functions and knee-specific pain going upstairs, downstairs, etc., and rendered, a PROMIS tool that's just as accurate and precise as one of these knee questionnaires.
Okay, I have a last question. I think we only have time for this question now. It is made by Anthony Sanz. What is the procedure to suggest or to participate in the translation of PROMIS tools to new languages?
The procedure is to contact us through Helena Correa is the person who manages the procedure, because very often, almost always, if there's something not yet translated, like a short form, some other part of the bank that short form came from has been translated or is being translated, and she has to coordinate all that to make sure that we end up with a coherent, consistent translation of an item bank, within a specific language. So Helena Correa is the person who manages that, and you can reach her through the website, but also you can send me an email and I can connect you with her, or we can put her email address on the screen, perhaps.
Okay, thank you very much, David, again for this interesting and useful presentation. Now it's time for the presentations by Gemma, Vilagut, and Jordi Alonso. But later we will have time for general discussion. So I invite you, David, to remain connected, and everyone, thank you very much for being in this presentation and for your questions. Over to you, Gemma.
Again. Hi all. Thank you very much for inviting me to this webinar, and I'm glad to be here with the presence of Dave. And well, I'm sharing my presentation. Hope, can you see it well? Yeah, okay. So here I'm gonna show you an example on the assessment of measurement equivalence of PROMIS mental health measures that we did for the measures in Spain as compared to the United States. First, I will start with a short definition of invariance to put everybody on trail in case anyone doesn't know about the concept. It's invariance is a property that assesses whether the questionnaire measures a construct, the same construct on exactly the same way according to different groups, across groups, for instance, gender or linguistic versions of the instrument. Or even we can assess invariance across time. And in order to be able to assess invariance, we need to ensure that items are, and the association between each of the items of the questionnaire and the construct, underlying construct being assessed, is not dependent on group membership or time. And this leads to the concept of differential item functioning, which occurs when given given two individuals from different groups that have the same underlying level of the construct, they would respond differently on a given item. The assessment of invariance is especially important when the aim of the questionnaire is to compare across groups or to compare the meaning of the construct across time, for instance. So when measurement invariance is violated or there is differential item functioning, this would mean that the scores of a given construct or concept would have different meanings depending on the subgroups, and this would lead to bias on the assessment. So here the objectives of these presentations are to assess the presence of differential item functioning across 4 countries, comparing Spain versus the US for the item banks of PROMIS, depression and anxiety. To do this, we use 2 online panelist samples, one for Spain, representing a general population sample of 1,500 individuals, and the online panelist sample used in PROMIS to calibrate the items for the US. And this includes around 780 individuals for each for the 2 item banks in the US. And to assess measurement invariance, we use Ordinal logistic regression methodology, where with this methodology, what we do is to compare 3 different Ordinal logistic regression models, where we add different variables in each model. In the first model, we only include the construct being assessed, so the latent score, in this case obtained with IRT methodology, and we add the variable of that indicates the group membership to the model, and we compare these two initial models in order to assess the presence of uniform diff, which indicates that the group, the influence of the group is constant across the continuum of the scale. In order to assess whether this influence on group of the group changes across the continuum, we add the interaction between the scale score and the group in the model, and we compare different effect size measures, like the R square between these models, or the change in the betas corresponding to in between each model, in order to assess whether there is invariance present. So we did this for the PROMIS depression item bank, which contains 28 items, and these are assess the presence of depression symptoms in the last 7 days, and it includes and the response options are 5 level Likert scales. When we assess diff, we observe one of the items from out of these 28 that was flagged for diff. This is the item I felt disappointed in myself, me sentí decepcionado de mí mismo. According to this item, when we look at the figure, we show that in Spain, scores for this item tend to be given a certain level of the continuum. Scores for the item tend to be lower in Spain than in the US, indicating lower levels of disappointment in Spain. However, when we look at the effect of this diff on the overall score of the test, we observe very little effect on the overall score. Here I show in the right figure the difference between the score not taking into account the diff compared to the score taking into account diff, where the item with diff has different parameters for each country. Okay, so and what we see is that the difference between the scores are very small, smaller than an effect size of 0.2, which is really minor differences. We did the same procedure for the PROMIS anxiety item bank, and the item bank has 29 items, and in these item banks, 2 items were flagged for diff, which are the item I felt upset, which was translating into Spanish as me sentí angustiado, and the item I felt worried, which is translated into me sentí preocupado. In both items, even though it's uniform diff, what is observed, we show that for one of the items, for the first one, the scores in Spain tend to be lower than the scores given the same value of the continuum. The scores in Spain tend to be lower than the ones in the US, while with the other item, the I felt worried item, scores in Spain tend to show higher values, particularly in the lower range of the continuum of anxiety, which goes from less anxiety to higher anxiety. However, as it happened with the depression item bank, the effect of these two items on the overall scale, the effect of this observed diff on the overall scale was low. And so what we saw in this exercise was that very few items were flagged for diff in both item banks, and also importantly, the impact of this diff on the overall score was very small. These results provide additional evidence on the cross-cultural validity of the instrument in Spain and allows for a direct comparability of PROMIS depression and anxiety scores between the US and Spain. And also provides additional enforcement on the adequacy of the universal approach taken for the translation of the items. Only to say that, especially for the anxiety items, especially for the worry item, which is one of the items included in one of the short versions, 7-item version of anxiety, it could be precaution not to use this item when cut assessments or use a shorter version that does not include the item, just in case. Thank you. Thank you for your attendance, and yeah, I'm ready. I'm here for your questions. Thanks.
Good afternoon. Good morning. My name is Jordi Alonso, and I'm very happy to be here with you today, especially after these nice presentations, interesting and engaging, I think, from Dave and Gemma. And I need help in the sharing of the presentation, so I will not be able to do it myself. So Yolanda, if you could start with the. I cannot see. I cannot see the presentation. Maybe it's already in, but I don't see it in my phone. Is it? Can you see the presentation? It was before. It is not now. I want to talk about PROMIS. I know this. I don't. Yeah, Yolanda. We need help with. It was okay before, at the beginning. So, okay, great. Yeah, can we go to the first one? Yeah, what I'm going to talk, could you put the first one just a little bit backwards? Yes, the Spanish PROMIS National Center. PROMIS, as you know, it stands for Patient-Reported Outcome Measurement Information System. It was a work developed in the United States for many years. And then after PROMIS, there was life beyond the funding from NIH. And because it was so impactful in this area, there was a lot of interest international. And I'm going to talk about the National Center in Spain, but which is similar than in other countries. What are the functions? What do we do? And we want you to know from us. So can I have next one? PROMIS, after the initial funding, created a PHO, the PROMIS Health Organization. which is the collection of researchers that were part of the PROMIS development, but also people that were interested in applying, using, and developing it further. So the aims of PHQ, the PROMIS Health Organization, is to advance science of health outcomes assessment, to disseminate standardized and validated health outcome questionnaires, and mostly PROMIS, of course, and foster development of new patient-reported outcomes, and educate the scientific and clinical communities in the science of PROs. PROMIS measures, PHO also promotes that PROMIS measures are maintained in a central instrument library, which is health measures. Dave Cella was referring to in several occasions. Health measures offers also not only the instruments and information, but the assessment center API to implement the CAT for individuals that provide their data and immediately obtain their scoring. Can I have the next one? So there was a lot of interest internationally. So PROMIS PHO started to go international, and then there's these national centers, PNCs, PROMIS national centers, with the mission of provide information, be a resource for PROMIS interest and use by individuals in the country, to have an educational, promotional, and also a community approach, so that we want more people to be knowledgeable and use, and then also interchange experience and improve and look for gaps in future directions. So, but we also we need to be responsive to questions about translation. There was some question earlier on, and where to derive these questions, how to solve these interests. The national centers, the persons that are members of the national centers, participate in overall meetings from other with individuals in other countries doing the same activities, attend the annual PROMIS conference, yearly conference that has two different tracks, one clinical and one methodological, that I think they complement each other so well, and provide information about the activities in the country. Can I have the next one, please? So there are some rules to get organized and to be most effective and also most consistent. Internationally, there's only one PROMIS national center per country, with one main representative for each PNC. Obviously, PNCs are committed with PHO. They are members. PHO is a non-profit organization, and it's actually people pay a fee for being a member. This fee covers some of the activities, but only a few of the activities that PHO does. There should be an organizational structure defined in the PNC, whether this national center, in our case in Spain, our institution is the PROMIS National Center. So we are a hospital embedded on we are a research institute embedded in a hospital and health service, and in a network of research centers like Vilagut. So PNC representative must have good understanding of what is PROMIS, and we've been part of PROMIS since long ago, and we are doing, as you've seen, some interesting research and applications as well. That's one of the missions of PNCs, is to promote the clinical use of PROs and PROMIS in particular. I think this is a crucial activity. Now it's more fashionable. More hospitals are now interested in using PROMS in practice, and so we need to make the case that how we can do it, how they can do it, how they can understand, and how this information can be informative for their decision making. Next slide, please. There are 19 PROMIS National Centers in the Americas, Europe, and in Asia. Next slide. And here you have, in the next slide, you have, well, you don't see, but there's the person and the center and the email address of each of those individuals. Next slide, please. So one of the activities that we have as a PROMIS National Center is to attend and promote the annual conference, the PHO, PROMIS Health Organization Annual Conference. And this year, the next conference is in next October 23rd, 24th in Prague. Interestingly enough, we hold these meetings just after the International Society of Quality of Life Research, the ISOC meeting. So we have some people that are interested in both things, and then they can have an extended experience. And this facilitates that concentrates in a few days a large exposure to PROMS research and development. Next slide is just an animation of Prague and how interesting it would be to go there after 2.5 years being basically at home. Next slide. An important issue that I wanted to comment, as you know, BiblioPRO, this is a webinar promoted by BiblioPRO. We are looking forward for the BiblioPRO scientific days that we used to have in the past, but due to the pandemic, it's a long time that we don't have too long time that we don't have this in-person experience. But BiblioPRO is also a way to find information about PROMIS. This is the today's homepage of BiblioPRO, and you use that repository to look for questionnaires. And if you go to this button this orange button in the bottom, if you go there and you look for a questionnaire, because you want to look for a questionnaire, and Yolanda, you can do that for me, and then a dialog window appears and asks you to write down what the instrument you want to look for. And you imagine you want to look for a PROMIS profile, and then you go Buscar, and if you go Buscar, then you find this information. You will see that you go at the bottom of the image. You will see that it's more than, I cannot see the number, but I think it's 14 pages. Each of one has a number, I think 10 different instruments that are PROMIS. And the first one in this list on the first page is PROMIS 29 profile. And then you click there and you go and you have information about the profile. You have, as this happens with any other instrument in BiblioPRO, and we have 2,400 instruments, so 2,400 instruments there, so which are PROs in Spanish. And so you have the name, the authors, the references, the correspondence, and other information for the Spanish version and for the original version. And then a little bit scrolling down in that page, if you go, you have certain characteristics of the instrument, the concepts or constructs, the number of items, scoring, etc. And then you can download several things. In this case, you are not downloading the questionnaire. You are directed to this famous health measures website, where you will be able to get that information, the PDF of the questionnaire you are looking for. Next slide. It's important that for you to know that we are going to be able to do more things for PROMIS from BiblioPRO. We, as I said, provide information, technical data sheet about PROMIS, both short forms, profiles. which have an official translation in Spanish. It's important, the concept of official translations are produced and approved by PHO Central. Historically, for a number of years, PROMIS were developed both in English and Spanish at the same time. This was the beginning, the first 10 years of the existence of PROMIS because of funding from the NIH and others. Now this is not the case, but there's still a lot of Spanish versions of PROMIS instruments in both item banks and so on. Soon we will be able, BiblioPRO will be able to provide permission for using PROMIS Spanish versions. If these Spanish versions are going to be used only in Spanish and in Spain. If the use of that Spanish version is within a multilingual international study, then again, translations at health measures is where you have to go. We will be able to distribute the Spanish PROMIS measures in PDF format for those users that do not have funding or they have only public funding and not for-profit use. And that's that's basically what I wanted to say. Thank you very much for your attention, and I hope that you get interested in PROMIS and that we can respond to your questions. And I'm happy to give you the possibility of questions, general discussion that I'm looking for. It's a good question. You want me to have the word, but I don't. I have difficulties in reading the chat with my phone. I really have to. I would prefer somebody else took that responsibility.
I'll just.
Okay.
Yes.
Okay.
One thing
I can do the questions for you.
Thank you, Manuel.
Yes, there is a question from Jaime. Can Spanish PROMIS versions be used in Latin America as well? This is to Dr. Jordi Alonso.
Yeah, but I will also will check on Dave. But my response is, we have, as Dave was presenting, the approach was a universal approach to translations. This is very in contrast with other experiences that we are very aware and very familiar and very happy with, but which is, for instance, the SF. That has Argentinian, Mexican, Peruvian, from Spanish. So there was methodology, there was, so to speak, science and qualitative research made to try to represent and to produce a universal Spanish translation. Obviously, the anthropologist in the room will tell us that this is impossible. And then I say, okay, you know better. But the thing is, 99% of the times, 90% of the times, I think the practice has shown that this universal translation is very clear in many places that have used Spanish versions. I can talk for Spanish versions, not for other languages that are spoken in several countries, but they may do that. Just to finish my response, nevertheless, we always find that some people may have less understanding of a particular word. And Gemma Vilagut was exactly presenting that not based on our qualitative work, but some qualitative work did find that some preferences, these might be regional, not even a country level. So we are aware of that, and Helena Correa, who is an important person because she's the coordinator of all translations in the world. She is American, but she's Portuguese, so she's Portuguese speaking and speaks many languages and understands very well the situation. We have solved the problems if there was any problem with particular word, and in some cases we have included in brackets an alternative word that was more acceptable in some country. This is exceptional, but it has been done. Dave, I don't know if you...
Yeah. Can you hear me okay? I have a few things to add to what Jordi said. We work very hard to create a universal translation. It sort of goes into the effort right up front. It's not always possible, as Jordi mentioned. Sometimes you need to make a change, and we do that when it seems necessary. And I think it does. If you go the other way and you translate multiple Spanish versions, it gets to be hard to know where to draw the line. Because, Argentinian Spanish is different from Colombian Spanish, which is different from Puerto Rican Spanish, which is different from Mexican Spanish, which is different from Spanish in Spain, etc. Continues. Then if you really, separate out in that way, then you have to consider the cost of, not financial cost, but the consequence of pooling all of those results in, say, an international trial where you may have 7 or 8 different Spanish translations, along with French and German and English and maybe 4 English translations. Then you're making a lot more assumptions about pooling those data. Gemma made a nice presentation on differential item function. Usually it's not tested. In those examples, it's just certified. Here's a certified translation. So I think it's important to weigh the cost and benefit of either approach. No approach is perfect and is always right, but we do strive for the universal, and as Jordi said, can achieve it most of the time.
Okay, there are no questions from the audience by now. Sorry, Jordi. Yes.
No, I wanted to say that the work that Gemma has presented is a step beyond certification, and it shows that there's no real metric difference, because it's less than 0.1 effect size. Most of the difference, this is negligible difference. So in the only case 1 in 7 or 1 in 20 that presented some statistically significant. So differential item functioning is important to flag, but then it's important to, as all the risks, it's important to interpret the magnitude. So I think that it is in favor of the universal approach, which I must confess that it struck me as a change of paradigm compared to all my previous career on this area.
Okay, thank you, Jordi. As there are no questions from the audience, I have one question for Gemma. When you talk about the differential item functioning in 2 or 3 items in your work, would you recommend to take them out for cross-country comparisons, or just to leave the instruments as they are?
Well, there are different strategies to do, well, to work around the differentiating functions whenever it is important. It could be to use different parameters for the items that are flagged for this, in case it is considered relevant, or even to take it out from the short versions or from the cut versions. It would be another option, yes.
Yes, Jordi, go
No,
ahead.
I was about to ask Dave if uh, do we do it basically we use the parameters that were derived from the US, which turn out to be maybe not totally replicable, but very practical, because puts everybody in the same ruler, and it doesn't. I mean, doesn't compare countries with countries, but I think that it simplifies. And I think the most important thing of PROMIS is all this effort in the interpretation. And Dave was presenting several strategies, and these strategies, well, now seem easy, but it took some time to develop this bookmarking, all these ideas. And then the minimal subtlety about the number itself, whether it's 50 for US or 50 for all the universe or all the countries. But this is a minimal thing in relation to the changes or to the targets that you want to get. The US may target 55 or 67, I don't remember the number, let's say 80, I don't remember. Maybe the Netherlands want to target 82 in the same scale, but the important thing is the same scale, and then we can compare progress in each country with the same ruler.
Yeah, well, I know time is up, but I agree that having the advantage of having a single ruler outweighs the value of having individual country calibrations. And I might also add that I've wherever I can remember, I've removed the U.S. general population from my slides and from presentations, and I just say a general population, because even in the U.S., we're no longer at 50. Those calibrations were done based upon 2010. It's 12 years later, and we've drifted. And rather than continuing to try to follow drift and go country by country with different calibrations, which would create all kinds of confusion and non-comparability, we just have a metric that has a, quote, general population score of 50. Now, like other countries, we've also drifted from that 50 in some of these banks. So that's maybe something to add.
Thank you very much.
Okay, I think we are running out of time, so we only have to thank you all the presenters and especially Dr. Cella for being here today. And it's over to you, Jordi, for the closing words. Thank you.
No, thank you, Mamen, for a great conducting of the webinar. Very happy that this happened, but looking forward to meeting in person with the next BiblioPRO Scientific meeting as soon as possible. And again, thanks all of you. Thanks, Professor Cella, Dr. Vilagut, and Ferrer, and yourself. Sorry, I prefer to say your names than your last names. And any questions you may have, please send any comments or questions that you may have on PROMIS and PROMIS BiblioPRO, and we'll make sure that you have a response from Dave Cella, from ourselves, and we'll be moving for PROMIS to be accessible from BiblioPRO, and especially in times of ICHOM and other initiatives. We think that PROMIS is a very good alternative, and it's actually included in some of these core proposals that ICHOM has. So thank you very much for your attendance, and see you very soon.